Hey, this is Dr. Andrew Oteo. We're going to talk about the research article, Who Pays for Poor Surgical Quality? Building a Business Case for Quality Improvement. So this was an interesting article. It went through the goals and the expectations of whenever there's complications with a surgical case, there's going to be more costs associated. It's going to cost more money for that procedure. And they broke it down with whether the hospitals or the payers are more responsible with this, or what are the incentives for reducing those costs. Both had a financial incentive to increase the quality of these surgeries, but at the end of the day, the payers suffered the largest financial loss. It's just going to be an output for the payers. The hospital's still going to gain something, but as we'll kind of go into, it also did cut into the margin of profitability for the hospitals as well. So that's why both are incentivized to have a positive outcome with these surgical cases. The primary statistical analysis they used was multivariate linear regression. Just an example of that is, strength and speed. You can see how there's a cost for complications versus non-complications. This was looked for cost and reimbursement, and we'll go into why they selected this, but there's a lot of benefits to using multivariate linear regression when we're looking at that. Obviously, it takes a lot of data. There's a lot of independent variables that are associated with this, and it's so difficult to take one patient and compare them to the next because of all those different data factors. So there's obviously a lot that they weren't able to capture with this. You can see how complex this can be when you're looking at a patient, looking at all the other information around that patient, just of saying, hey, this is one surgery compared to another surgery that's similar. This looked at 1,008 people, so it's still like a moderately large level of data that they were looking at with this one. But I just want to kind of go through some of the considerations with this study, the things that I really didn't like or had questions about. They put these in the National Surgical Quality Improvement Program, which we don't really know what that is. It doesn't really tell us. It was a single hospital system, so it would have been great for them to pull from different hospital systems. Obviously, that would make it a lot more complicated, and it was over a 2-year period of time. There's also part of this sample they were upfront about is it did include 40 consecutive adult patients. Most of these were vascular operations within an 8-day period of time. So there wasn't a lot of random selection, quite a bit of chunks of patients. They didn't break down the complication rates of different doctors. That would have been interesting to look at too, of how does Dr. Jones do versus Dr. Smith. My thought process always goes to, well, who's benefiting from these surgeries? Obviously, the hospital is, the payer's not. The income of the doctor, what is the doctor making? That's something who's benefiting from it. This study relates complications with poor care. A complication means there's poor quality care, which we know isn't always the case. They just kind of clump the patients together when it comes down to that. Diversify the selection of patients to include surgeries other than colon resection, abdominal aortic aneurysm repair. So they only took certain types of surgeries, really just looking at all surgeries. They only did really 3 different types. One of the things that I found through my research was activity-based costing, and it does look at direct and then service center costs that are associated with it. You can see the breakdown of this. This is a full consumption costing of a lumbar spinal fusion. So I really like this breakdown that they had, because it really shows where's the money going. When we look at the breakdown of what happens, the profitability, how complications truly drive down profitability for these hospital systems, that's what I would be looking at as a business owner is, where are the costs going? Is it the surgical services, the nursing, interventional diagnostics? There's different stuff that we can be looking at that says, hey, if we drive this down, or if we are able to control costs on this end, that could also drive up profitability for us. There's other things that we could do if we're kind of keeping it similar to what they have right now with the linear regression model. Then I would look at a multiple linear regression model with interactions to show how this stuff really kind of fits together. There could be other things that they pull from their data that really could help the hospital system with their cost saving steps. And I think that goes back into what we were just talking about, activity-based costing. Could be a preset to break down consumption factors that are eating up this profitability. The one thing that I'm always about is I'm patient-centric with my approach. And it would be interesting to look at a patient's consideration. What is the cost to the patient with missing work, with additional healthcare expenses? And this doesn't really address any of those things with this study. And obviously, as a healthcare provider, my intention, I really want to provide quality care for patients. The more predictive models that we can create like this can really help to allow us to say, hey, this patient with these types of complicating factors, comorbidities, age group, whatever it might be, these people are more likely to respond in a certain way. And that'll obviously help to, based on what this showed, complications drive up the cost. So it's going to drive up the total collections, which is great, but it drives down that net profitability because of the additional expenses. So if we can identify, what are those additional expenses, eliminate those, and then what are those complicating factors, and working towards identifying those so we can be proactive in our approach versus reactive and obviously driving down profitability. But that's the biggest thing, is just looking at the patient mix, looking at the research and the data surrounding that, and trying to draw conclusions based on that to ultimately, number one is help people in a more meaningful way. Number two is create more compliance. And number three is truly becoming more profitable as an entity. Here's the references that we had with our data, and I hope y'all enjoyed the discussion and have a wonderful day.